And there you have it, three very different perspectives from three becoming more closely aligned parts of the healthcare area. Do we have microphones? Okay, so I'm going to open it up to questions. Jack, you're first. You raised your hand first.
Hi, I'm Jack Nealon, Chair of the Department of Health Policy Management for the School of Public Health. Those are three terrific presentations. I probably have about 3 dozen questions for you. I've been trying to figure out which one I wanted to actually ask, and I'm still not sure I've got the right one. You focused very much in thinking about what's going to happen in the next 12 months on where you sit. So we heard a little bit about how health plans are likely to evolve, how physician groups are likely to evolve, how healthcare systems are likely to evolve. I didn't hear a lot of discussion about patients. We talk about increased integration. We talk about changing digital environments. You've talked about increased bundling of payments and increased changes in the metrics for evaluating each of your organization's performance. Each of those have risks for patients as well as potential gains for patients. And I'd like to know how you think over the next 12 months the patient experience is going to be changing in each of your organizations, or your beneficiary experience is going to be changing in your organizations. And on balance, will patients be happier or less happy at the end of the next year?
So I'll be happy to make a stab. It sort of depends on which patient you're talking about. I mean, there's many things to be said in response to that, but briefly, a big thing that's going on now across the really...
Well, let's focus on the 20% who are actually going to cost us the 80%.
So I was going to say the 5% that drive the 50% of cost. That's precisely what I'm after. So certainly what my members are doing now, like never before, is data mining to stratify the population, find out who that 5% is or who that 20% is, and then bombard them with services to keep them out of the hospital, keep them healthy, and keep them happy. So if we look at that swath of the population, I think they're going to get better care than they've ever gotten before, because that's where the high cost is, and that's where the quality initiatives really need to be focused in the main. So that's, there you'll see a very patient-centered kind of work there. The other end of the spectrum, invincible 25-year-old surfers and so on who sprain their ankle, I don't know that the world's going to change a lot for them. That's a very kind of episodic thing. But the whole business about risk stratification and then outreach to the higher intensity patients, that's sort of the name of the game right now in terms of population health and population management. So we're going to see a lot more of that.
Maybe I could just add briefly that, you know, I think for all of us, and I know Tom and Don pretty well, that it really is all about the patient. So if our comments didn't come across that way, we kind of are using shorthand when I say things like triple aim. It's really all about that patient. So I think we're all pretty centered there. I think in a 12-month period, they are going to be happier. I don't know that we're going to have dramatic breakthroughs, but we are going to see things that do matter. For example, there was a fair amount of confusion with the smaller networks that were introduced in the Affordable Care Act. I think there's going to be much clearer information that's available, much clearer understanding of the product that I'm buying and the network that I'm buying. I think some of the just basic information, services will have improved and will take away some of the noise that folks experience. And I think you're going to see incremental shifts and changes for the folks that are the sickest, that cost us the most.
Yeah, I would second the point that I think all of us have the kind of the patient's interest at the heart. It was embedded in everything that we were describing. I think with regard whether people will be happier or not, I'm not going to make that prediction either. But I will say this: I think by all of the objective and professional measurements of providing a higher quality, more clinically cost-efficient care for those patients and other patients, I think we will be a year's worth of incrementally further down that road in significant improvement. as a result of a whole host of interventions being done both in the ambulatory setting, in the physician component of our organization, as well as in the hospital. So dealing with everything from the patient's when the patient's discharged, the transfers to skilled nursing facilities and back, all of those interfaces, the convenience of patient access, being able to be seen in a timely way. I've made reference to patient engagement and the use of mobile technologies. We've got a whole agenda, like many other organizations in town and around the country, making use of that for those patients that I think will enhance. Here's what's going to continue though for some time. The American healthcare delivery system is I don't know, I'm trying to find the right description. A quilt. It's a patchwork of different kind of systems. So everything I'm describing to you is the things that can be brought to bear for those patients who are being treated in organized, coordinated delivery systems. There remains today a significant number of people who are treated in you had a great list of adjectives, disorganized, uncoordinated care. And for those patients, some of whom come to the hospitals of the healthcare systems I was just describing, who have the capacity to deliver it for those who are part of the integrated system, those patients may have a different kind of experience. Now, everyone's also working to try to make that uniform across the spectrum, but it takes a lot more effort and takes a lot more time to be able to deliver that kind of capacity outside of the integrated section or segment.
One thing I overlooked. Patients are going to hate the high deductibles. So there's going to be problems in terms of the financial side. The healthcare's still too unaffordable, and so they may love care or hate care. One thing that's going to be big time, and that is the backlash against high deductibles. Get ready for that soon.
I just may call out also I thought, when we say there's incremental improvements to treating the sickest of the population, probably more apt way to describe it is, I think there's going to be breakthroughs, but they're not going to be everywhere. They're just going to be in smaller places. It's going to take a while to scale those up. And Tom, for example, was telling me about some of the major advances they've made in their hospital on this front. I know we've introduced this oncology practice of the future in a couple places, and it's dramatic what the patient is experiencing, but it's only a small number of patients in that geography, and getting it spread so that it gets to thousands or millions of people takes time.
Other questions?
I guess this would be for Mr. Markovich. What role do you see insurance companies playing in medical tourism?
Medical tourism, well, to me, the way that I look at everything through our lens is we have a mission. It's to ensure that all Californians have access to high-quality health care at an affordable price. And the way that I talk about it inside our organization is that means our job is to transform a dysfunctional system that's bankrupting us into one that's worthy of our family and friends and sustainably affordable. So that is the litmus test for whatever we do. God forbid one of your loved ones needs to access the system. A, can they afford insurance and access it? And B, when they get there, are they getting treated the way they ought to? The way you'd want them to at their time of greatest need. So when we think about anything, creating an ACO, contracting with a provider, the question is, does it further that goal? And I don't know the answer on medical tourism, to be perfectly honest with you. And there's a tension point, I think, in the healthcare system between a couple different philosophies that are ultimately going to need to come together. One is a philosophy that says, well, let's just make the member, the patient, a customer, right? Let's give them all this information. They'll do cost and quality. They'll go shop for their MRI. They'll go shop for their prostate exam, right? And there are benefits that you can get from that. They're limited. If someone's having a heart attack, you don't want them grabbing their phone in the ambulance and figuring out which quality criteria to look at. It's like, no, take an aspirin and just get to the hospital, right? So, so medical tourism probably falls in that, well, I can compartmentalize the procedure and put it over here, whereas there's a whole lot of evidence that when you have an integrated approach, if you do it well, you're going to get a lot, you're more likely to get to the triple aim at the end of the day. I do think in the integrated model, we have to figure out how to get the patient or the member more engaged with financial incentives so that they are a part of the conversation. And some of the things that are happening on the patient as a customer side can be very helpful for that. So to me, I don't know the answer specifically to medical tourism other than that's the lens that we look through. And I think we have to be careful not to take this patient as a customer notion too far, because in the process you can lose the opportunity for coordination and integration.
Okay. Yes, young lady.
Hi, you mentioned in your presentation about federal subsidies that will be maintained in the next year, and also you said that at least one large-scale acquisition will happen. Since both are two intertwined, and also what was mentioned during the presentation is that there will be high deductibles as well as high costs for oncology drugs. What do you think would happen to costs at the patient level and in general at the aggregate level? Thank you.
What's going to happen to premiums, you mean? Or costs? I didn't quite hear the very end. The very most important part I didn't quite catch.
Yeah, the costs at the patient level and then the
Yeah.
costs at the macro aggregate level.
Well, I mean, what's the good news has been, if you look historically, is healthcare trends have come down from where they were. That's the good news. The bad news is that the costs are still outstripping wage inflation. So when we look at what is affordable, we've gone out and said what we call is the total cost of ownership. So it's not just the premiums we charge, it's the typical out-of-pocket payment somebody has to have, because that way, otherwise, look, anyone can make something. I can go out and do a $20,000 deductible if regulators allowed me, and I could be affordable overnight. But it's not really affordable, right, for somebody on the ground. So we look at the total cost of ownership when we benchmark our plans, so you don't get into this benefit design, high deductible thing, kind of cheating your way to saying you're affordable. But if you look at today, if you take our most popular product, total cost of ownership, family of 4 in California, it costs over $16,000 a year. The median income for that same family is between $60,000 and $65,000 a year, which means if they were paying for it themselves, it would be more than 26% of their gross income, not their take-home pay. That is not affordable. And every year, price inflation for premiums outpaces wage inflation, which has been around 2%. It gets worse. And so that is why, to me, these integrated, coordinated approaches, the deep integration that I was talking about, working that with a sense of urgency, probably with a select number of providers in smaller networks, is going to be key to getting to that triple aim and including affordability. In the meantime, I think what we're going to see is probably fairly stable at the macro level trends for most products, but that still means an already unaffordable product in many respects is getting more unaffordable and is not sustainable.
I would only add to what was just said by Paul, that I think he's accurately described the pricing situation and the individual. You know, total spending in the country is going to go up, and it's going to go up. We are, in spite of all the work that you're hearing described, and I have to say, I think, you know, as I talk and meet with colleagues around the country, what we're talking about here tonight is happening in delivery systems around the country. There's a lot of incredible work. The challenge is some just fundamental underlying demographics. There are 8,000 baby boomers turning 65 every day. Every day, 8,000 people. And the attendant realities of the aging process that come along with that will be very hard to overcome to really significantly moderate total spending. And that's where this squeeze that we're talking about is going to get worse.
I'd also like to thank everyone for your presentation. It was very informative. Tom, you brought up the issue of 30% of the marketplace in California being Medi-Cal.
Mm-hmm.
One of the issues that is specialists that will take care of those patients.
Right.
With the influx of all these patients now demanding care and thinking that they have insurance, they're ending up in our emergency rooms for care, and we are trying to refer them out, which is an impossible job. What I'm wondering is there any strategy, not that I expect that this group is going to come to that solution, but is there any strategy between the insurance industry, the physicians, the hospital industry, and the government to improve the number of physicians available? Because whether we have physician extenders or whatever, our system is still based on physicians providing medical care or guiding the system.
Right.
And that's a question that needs to be answered.
I'm unaware of any kind of coordinated effort of the kind that you're describing that's out there. I think, and I think the issue, that's where the whole discussion about the amount of Medi-Cal payment rates comes to bear on this particular question. With regard to the physician supply question, there are a number of new medical schools, I think, about to be launched in California, but that's an 8-year, that gets you down the road 8 or 10 years from now, right? So that's not going to be a tomorrow issue. So I think the problem you describe is going to remain with us for quite some time. In the meantime, institutions, I think, are looking to care for these patients as much as they can afford to care for them. But there's a real issue related to the relative payment level for Medi-Cal patients compared to the real cost, not what anyone's charging for it, but what the real cost of caring for them is, and the implications that has for commercial prices. There's some $8 billion worth of underfunding for Medicare and Medi-Cal in the state of California among hospitals alone, that 95% of which is borne in the network model health plans in the state. Probably commercial prices, in the hospital commercial prices could come down by 30%, rough number, 30%, if the losses being sustained under Medi-Cal weren't with us. There's no real discussion going on about that kind of phenomenon.
Don, do you want to?
Well, I was just going to say, there is a debate, of course, about physician supply. Certainly one of our views is that if the physician supply we currently had, if those physicians were deployed in doing what they should be doing, we'd have enough physicians right now. So presently 30% of the cost is spent on care that's unnecessary or frankly wasteful. So if you peeled that out, that would make a big difference. If you were really using team-based practice as it should be done and using mid-levels and the team properly, you would be leveraging the services of those physicians more efficiently. Were that done universally, we'd be having enough physicians. We would have enough. The real issue on Medi-Cal, though, is the reimbursement so absurdly and ashamedly low. I mean, I can't even, it's like 60% of what Medicare is or less, and so on. And there are efforts underway, legislative and otherwise, to fix that. There are other sort of programs, almost gambits, to generate revenues to match the federal match and so forth. The hospitals have one, the nursing homes have one. We're trying to do one to elevate Medi-Cal compensation to Medicare or community rates. But they're one-offs, they're small, they're transitory. We just really have a fundamental problem of Medi-Cal being just really ridiculously underpaid. That's the problem. The access would change overnight. If Medi-Cal were paid at Medicare rates, the access problem would change overnight.
Could I ask everybody to introduce themselves before they ask their question, too?
Scott Flax. What are your thoughts around employer groups and how they may influence, or bend the curve in terms of change in healthcare over the next 12 months or so, especially since they bear the cost burden for most of the healthcare today?
Yeah, I think they have a major role to play, and it's not even just in what products they purchase and how they go about that, but those decisions, especially for larger purchases, look, they're a customer and a major customer, so the health plans are going to try and jump when they ask us to do something. So they have a chance to influence there, but even more so, and this isn't talked about so much, is think about how much time people typically spend at work and how much things like how sedentary you are in your workday, how that has incredibly pernicious health effects if you're too sedentary, the kinds of meals that are available. There's incredibly small things that can add up to really big differences on life and health habits that your employees have when they're in the workplace. And so beyond just, are they buying value networks that are trying to do this type of integration and this work that we've been talking about? Are they moving to plans and providers that are trying to be technically integrated in the way I described and getting out of the clipboard business? I mean, those things can help influence care. But as much or even more so, I think, is there a cafeteria nearby that provides healthy options? Do you have an option? In every one of our work sites, we have an option to have a walking workstation. You can walk up to 2 miles an hour while you're processing a claim, answering the phone, et cetera. Are you creating that kind of environment where people can be moving, active, easily making good lifestyle choices? Those things can make a really big difference.
One trend that's worth noting is that, well, employers are angry. they are unhappy with the kind of spend that they're facing now to cover their employees. One trend, among many things that could be said, though, is that they're moving from insured products into the uninsured world. So there's the question. So the ERISA self-exemption is attractive to them, where they avoid a lot of the costs associated with the kinds of quote-unquote consumer protections that are found in the Knox-Keene Act. So we have a very unhealthy trend going on where they're moving from fully insured HMO, coordinated care kind of products, shedding all of that to move into self-insured, where basically it's PPO, and they can have high deductibles, thin benefit designs. There isn't a lot of coordination. It really is not what Sylvia Burwell, our Secretary of Health, has asked for, which is a movement towards risk-based contracting, 50% by 2018 and so on. So we really have an amazing trend in the state here, California, which is really sort of the fertile crescent or something of coordinated care. We have this movement from not volume to value, but from value to volume among a lot of employers. So it's counterintuitive, but it's one thing that's happening.
I just add that there are many employers actually that are pursuing a number of creative strategies to deal with this issue. The Safeways of the world, the Boeings of the world, a number of companies like that doing a whole variety of creative kind of contracting models. The other thing, and actually none of us I think brought up specifically, but private exchanges are something that I think a lot of folks are looking to. It's largely being used as among other things, as a mechanism whereby employers are moving, though, from a defined benefit plan to a defined contribution model in the course of going to the private exchange approach. And I think we're likely to see significant growth in that area.
Could one of you please explain a little bit more in detail how private exchange works?
Sure. I mean, it really is just a situation where there are a number of benefits consultants and other organizations that are creating a grocery store, for lack of a better term, of health plan options and putting them in a package and saying, well, this collection of plans, this collection of insurers are all available, and then you just set a contribution, as Tom said, it's a defined contribution. Here's how much money I'm going to give you, employee. Go shopping. But you're going shopping in a controlled environment with specific options. There's often risk sharing and risk adjusted premium involved in that, because you can imagine how risk selection might occur with that many plans. So that's just the general notion of it. All the mechanics that you get on the Covered California State Exchange, you kind of just copy, mimic, and present to a specific employer group.
With the increasing role of government as payer in a lot of instances, whether it's through federal subsidies or whether it's through exchange, whether it's through Medicare, with the growth in Medi-Cal, and the strong potential of another Democrat in the White House, do any of you think we're going to hear the clamor for single payer
No.
I think we're going to continue to hear noise, and some call for it. I think, though, that a very instructive lesson we saw recently with Vermont, where they had teed up a single-payer system for that state. This is a matter of months ago, and a strong movement. And I think it passed both houses of their state legislature, and then they basically scuttled it. The governor and their legislature scuttled it because they finally, I think, realized that it was cost prohibitive. So maybe the leading example of a single-payer system was withdrawn by the very architects of it. So that's a lesson, I think, perhaps. It's tough healthcare is expensive, and so it's tough to be a government paying for all of it.
I just find interesting by way of observation that while an increasing amount of the payment is starting with the federal and state government, when you think about subsidies for the exchange, Medi-Cal, Medicare, they're also increasingly looking to the private sector to help. So an increasing portion of Medicare beneficiaries are going through the MAPD program. And at the state level, they're pushing more and more into managed Medicaid, including doing a dual eligibles pilot. The exchanges are all private plans. And so it does beg the question, if you were to, this is where generally the single payer efforts fall over, isn't it better if we have single payer? Great, now what? Right? And so how do you actually go physically pull this off is a question that, and actually finance it, is a question where it often falls down.
Just to elaborate briefly, part of the issue is Americans love choice. Seriously, all kidding aside, I mean, as a cultural matter, Americans love choice. And I think that unless someone can come up with a way of architecting a single payer or tax financed, which is the better way of describing it perhaps, system, and that can still have elements to it that can satisfy Americans' love for choice, I just don't see there being enough social acceptance in order to get the political will to do what you're describing.
We talked about data mining, digitizing, personalized medicine by way of cost. We're getting closer and closer to people's genetic information being a part of their personal health record. And your comment about choice is very much a part of the question. How do you control the outreach of health payer organizations who are reaching out to higher risk populations? When you have their genetic information, how does your outreach not turn into coercion? Thank you.
Is that directed at me, or is
I wasn't. All kidding aside, I was kidding aside. I wasn't clear whether your question was related to the provider side or the health plan side of it. Seriously,
it's
or both.
Related to the whole issue of public health care.
Right, right. So I get what I would say is I think that that individuals' genetic information in terms of how it's treated today is treated with the same privacy protections that apply to other medical record-based information. So whatever providers have in their medical records regarding the genetic profile of an individual in their medical records would have the same privacy protections that all medical record information has today, whether that's someone's blood pressure or their weight or their obesity score, things of that nature. So that's the best answer I can offer from the provider side.
Go ahead, Tom.
One other thing I'd add is that underlying the question is the notion that insurers and providers would eschew patients with a bad health profile revealed in some genetic testing, right? And it's largely true. But the point I'll make is that for my members, now they actually do well with acutely ill patients. This is a big change. We actually now, provided that we're paid actuarially sound, risk-adjusted capitation, we do best with those seniors that have multiple chronic diseases. So the logic underlying this is if, for example, we learn that someone is, through genetic testing, has a propensity for chronic disease or something like that, my members in many cases would want that patient provided they're paid adequately for that patient. That's where we do our best work. The reason I make that point is that there's really a kind of a paradigm change that occurs when you ask providers to take financial risk, and that's underway right now. So I just throw that into the mix as I don't give you a very good answer, that the way the psychology of delivery will change is going to change as well.
I would just say I'm not really worried about it turning into coercion or people being left out in the cold because of some greater level of detail for all the same reasons that Don mentioned. I actually worry far more about data security. And I don't know how many of you noticed that with the data breach on Anthem, there was a couple of months afterwards that a Washington Post article came out, and they said the most likely candidate for having done this is a Chinese-sponsored government hackers. And so let's just assume for the moment that was accurate. You're talking about potentially trying to keep this data secure from nation states. And they are extraordinarily sophisticated and very persistent when they want to get after something. And so I think one of the things that's going to need to happen, because we're talking about more and more data, which is needed. If we're really going to get to the personalized medicine, which I think we all want to, and is going to hit that standard of care that's worthy of our family and friends, we're going to have to cooperate and coordinate more about how we make sure this data is secure, because any one institution on its own is going to have a hard time standing up to a foe like that, that's that persistent and that sophisticated. So I worry much more about the overall security in our current environment than I do about any kind of coercion.
Hi, Ron Clausen, a student of the School of Public Health here. My question is, with the upcoming adoption deadline for ICD-10, do you see any significant impacts for your organizations, excuse me, coming within the next 12 months?
A lot of physician depression.
Yeah, much higher use of Prozac and other
I think the ICD-11 policy issue is probably going to have to go on hold, yeah.
Yeah, no, all kidding aside, I don't think folks understand the degree of impact this does have on physicians. And we had the topic we haven't talked about is there's a growing amount of physician and other provider fatigue out there with all of the changes that are going on. And ICD-10 is going to just be kind of the next one. And it's going to be a challenge.
The irony is that we've invested so much to get ready for ICD-10 that recent suggestions that it be delayed, we've actually opposed. Right. You know, we hate it. And that's probably the wrong word. I think it's better to say we've worked so darn hard breaking our neck to get ready for it. Just bring it on, or leapfrog it entirely and let's go to ICD-11. But I mean, I think Tom's right. It's just a ton of work and expense to get ready for a massive coding change for everyone.
If I just may take 30 seconds for an infomercial here, I do think this is a great example of we got to be much more thoughtful about when we introduce regulations. There's a whole lot of people that think there's all these different things. The amount of things that we're mandated to do as a health plan, that Tom's mandated to do as a hospital, it ends up being busy work. And I mean, ICD-10 is not about changing care on the ground, doing the things we've been talking about, achieving the triple aim. It's a lot of work and a lot of energy, and it's actually a big opportunity cost from working on the things that are going to be much more impactful. And so I think it's a great lesson learned as we go forward, and there's all these potential clever ideas of what we all could do and should be mandated to do, is if you're going to do that, let's make darn sure it's high value. Because if it's not, let us just get busy trying to make this happen.
Question for Don. In terms of the SGR fix, what impact do you think that will have on participating physicians in Medicare? Looking at those
So you heard my prediction that the great majority of them will go into APMs. So I stick with that. You mentioned the word demographics, which is really key. Faced with all of physicians of the world are overwhelmed with all of the administrative work, the multiplicity of different quality programs, all the administrative work. The demographics are really important. I mean, I think into my answer I would sprinkle the following. For physicians that are above a certain age, let's just say 60 or something, you're not going to get a lot of adoption of new stuff. They're going to ride it on out through their retirement, which would be a logical thing to do. On the other end of the spectrum, physicians coming out of medical school right now, they've never known anything but a digital world, and they want it and they expect it, and so you'll get high levels of compliance of all the stuff we're talking. In the middle is a sort of a different picture, and that's where physicians are trying to figure out where they sit in the world. Do they really, they never really wanted to join maybe Kaiser, but they might do it now because it's in their economic benefit. They never really wanted to be in an IPA, but now they'll do it. So the demographics, age, and gender also, and life-work balance issues and stuff will play a role, but I still think they're going to be pretty much obliged to get into organized system because so much of what we're talking about requires systemness, and that takes capital, it takes know-how, it takes management, it takes all the stuff we've talked to. So we are moving into a world where we're looking at sort of organized systems, whether they're just physician group-centric or hospital-centric, whether they're the perfect menage a trois of plan, group, and hospital, whatever they are, they're going to involve sharing of information and personnel and savings and profits like never before. So that's how I would answer that.
We need to take at least one more question. I can't have that picture in my head.
Okay, we need at least one more question. We actually have time for 2 or 3 questions, so why don't we do 1, 2, 3 in the back.
Rod Shader. I wonder if you have any comments on the effect in the short term that parity legislation might have for behavioral health services, which historically have been both underfunded and underintegrated with the rest of healthcare, and the fact that with healthcare stratification, risk stratification, in that awful 5%, there's a high prevalence of substance abuse and mental health problems. Do you see this as having a short-term effect on shaping healthcare in the next year?
I think on the physician and delivery side, actually unrelated to parity, but I think parity enhances it. There's already been a movement started to basically strengthen the mental health component of all these organizations' capacity on the service delivery side. It's an example, actually, I think, of where the integrated coordinated model and capitated payment provides the incentives that can, I think, turbocharge that kind of move, because there is so much of a comorbidity related to mental health in so many patients, and particularly the high-cost patients. It's part and parcel of it. So if to the extent that the payment model moves more and more in that direction, then I think you'll see the parity legislation be helpful in that regard. What that has from a total cost standpoint, I defer to my colleague to the left here.
No, I think if it's done well, I agree. I just want to say ditto, because if it's done well, this is, I mean, it's going to be a beneficial thing. It's ultimately going to improve quality, and I think long-term it'll improve cost, because everything I've seen on this subject is folks that have those conditions tend to bounce around the system. I mean, they have lots of comorbidities, and they're trying to, they have this pain, and they're dealing with it in other ways. And until you figure out what's really at the source of it, you don't get the quality of care, and the costs are extremely high. And so I think doing it in the system and doing it well will ultimately be the right thing all the way around.
Plans who didn't offer initially to go on the public exchange, if they're going to start maybe, hey, now water's good, we're going to come in, and if people who initially signed on, if they have, expressed satisfaction with the metal level they chose initially, or if you're seeing a lot of movement, people who, pick silver one year and then like, no, doing platinum this time, things like that.
Well, I don't know, Don, did you want to?
No, put me in the queue.
No, that's fine. So, yeah, it's a broad question. I'll try to answer briefly. I think overall, net, if you step back, you've got to be pleased with how California has handled this and launched it. I mean, as much as the 1.3 or so million that are in the program now are very much at the low end of what was forecasted after the second year, the fact that there's that much membership in it and enough critical mass that you don't have what you have in some other states, which is a real big risk selection problem. Small population, nothing but the sickest, a potential, they're dealing with or potentially having to deal with serious death spirals. There have been certainly, it has not been a perfect service rollout, but it's been much better in the second year than it was in the first year, and I think it's going to get even better the year after that. The outreach to minorities, for example, has improved. The Hispanic population the second time around, that's been documented. A lot of smaller networks have been included, and there was just a recent article about the fact that the quality of those networks, in fact, is maybe a little bit higher than the broader networks that have been put in place. What I see needing to happen, just when I look into the future, is the way that it was initially set up, it made far more sense for a health plan like ours to do a directly contracted fee-for-service model, and for all the reasons we did it that way. And yet what we're really looking for ultimately is a much more integrated model. And I think that's what you're going to see a movement to in the coming years as this matures, and now we understand it and we know how it works. We know how we might do, for example, risk-adjusted premiums along with risk-adjusted capitation in a way that could work. I think you're going to see more of that movement.
So that's Paul's final point that I was going to pick up on. That's our problem with the exchange. Much about it is really to be applauded, frankly, particularly when you compare it with other states. But from our perspective, the exchange, as we look at it today, snapshot, is almost devoid of capitated accountable care. I mean, it's almost all PPO and sort of EPO, where plans are contracting directly with physicians, moving us in the wrong direction, the very opposite direction that policymakers want us to go. That trend needs to be reversed. Paul's alluded to that. There's systematic and kind of structural problems that give rise to that, but we need to fix that, because if it's marching us in the wrong direction, then I don't think it's going to serve us well. So that's an interesting factor.
Ditto to what's already been said. I would only add, I alluded to this in my comments. So the first year, I think both on the provider side as well as on the health plan side, people took a conservative, cautious posture on every angle, every element of the contracting piece. And comes year two, I think the picture's a little clearer. People have an understanding of where things are. And as happens in markets, new equilibrium points begin to be found. And I think that's a part of the story for the second year as well.
Okay, we have one final question, final short question, Frank.
Sherry News. We talked about the abysmally low rates of Medi-Cal in the state, and there's a lot of medical groups that are members of Don's organization that have Medi-Cal managed care contracts. Paul's company just bought Care First. These contracts are, of course, fixed rate. And so now in Los Angeles, we have the Los Angeles City Council passing and the mayor signing an increase in the minimum wage law. I don't know how much this affects. I can tell you in some of the groups I work with, it's upwards of $1 million a year. Those rates will not be offset, I don't think, unless the state has a fit of rectitude and they want to make things right. So I don't know how we adjust to that. I don't know how it's going to affect things. But it could be a problem. Any comments?
Is there a question there?
I think the only thing I'd offer, Frank, is I think when that situation occurs in other areas, it could trigger consolidation. so that those who can't afford it becoming part of those who can figure out how to absorb that in their larger entities. That's speculation.
I mean, I just go back to the global comment I made about the fact that all of this goes back to it's not affordable at its current level and not sustainable. You know, the state doesn't have the money, federal government doesn't have the money to keep paying at this level. And the way that governments tend to deal with issues is they just change prices. I mean, that's just and that's not just the U.S. government. You look all the way around, you look at other systems in other countries, how do they manage healthcare costs? They just squeeze prices. And we have to figure out in all these populations how we can manage to make it affordable and high quality. And fortunately, with the way the system is right now, you have to improve quality in order to get sustainable affordability. So there's no tension point between those two. But we got to figure this out, and when we can, then there's enough money in the system to make all this work. But we have to figure out how to make the money that's in the system work. And when we do that, we can deal with all that.
Okay. Excellent. Well, thank you very much to